Good afternoon, ladies and gentlemen. With the permission of Professor Malюgin, we will start now this ESCRS session. As you know, the European Society of Cataract and Refractive Surgery is currently the common home for anterior segment surgeons in Europe. We have many members, thousands of members across all Europe, and we provide a number of services, including 2 annual meetings, 1 summer meeting and 1 winter meeting. Next winter meeting will be in Maastricht, Holland. Next summer meeting in Lisbon, Portugal. And we face a lot of success even with our Russian members, because the Russian ophthalmology is great, and this venue is the venue where it has been greatest, and it is greatest. And we thank Professor Malюgin for inviting us as an academy to be here. ESCRS Academy is composed by prominent doctors in their own countries, providing the state-of-art knowledge about a few items of common interest. And today we will see 12 lectures from a few of our most important doctors here. So, thank you all for hosting us in this venue of particular emotion for us, and let's start. Our first speaker is Bekir Aslan from Turkey, that will talk with us about cataract surgery in angle closure glaucoma.
Mr. Chairman, ladies and gentlemen, my dear colleagues, I am indeed privileged to be on this podium. To be on this podium means that you are speaking in an area where there is an unbelievable inheritance. I really very much congratulate you that you have this inheritance. Of course, it not only belongs to you, it is an inheritance that belongs to the whole world. And I really congratulate you. Now I'm going to speak about cataract and angle closure glaucoma. This is a wide spectrum topic, and I will just try to summarize and try to be as more informative as possible. I think I'm going to move this like that. Okay. Well, first of all, when you see an angle closure, it's better that you look for why this angle closure is happening. Well, effusion may be the cause of the angle closure, and some antidepressants, anticoagulants, adrenergic antagonists, sulfa-based drugs, and antiepileptic drugs should be looked for just for angle closure. When you have a patient following general anesthesia, angle closure may be also an issue. Snake venom, lenticular and zonular abnormalities are the other topics that we have to understand. Of course, our topic today is lenticular and zonular abnormalities. And all of them is also related to the increasing age, increasing lens thickness, female gender, hyperopia, and ethnicity. Apparently, some Eskimos and East Asians have more angle closure than the rest of the world. Cataract surgery as a treatment for angle closure glaucoma is somehow a way to go ahead. Primary angle closure glaucoma may affect 15 million people worldwide. So I am speaking about a topic that really have an impact on a lot of population. There are some treatment options. If it is at the acute stage, dynamic gonioscopy is the way that you have to go. Some oral carbonic anhydrase inhibitors, topical cholinergic agonists, hyperosmotic agents, and apparently laser peripheral iridotomy may be the technique to follow. Ongoing chronic angle closure glaucoma, you have different options, including medical and lens extraction and trabeculectomy, or trabeculectomy plus lens extraction, and of course some laser release of goniosynostosis, which is also an important role of treatment. Cataract surgery, of course, the acute form is characterized by sudden pressure elevations requiring emergency. Laser treatment or incisional surgery may be the choice. But instead, even if you do these surgeries, episodic pressure spikes or a progressive increase in intraocular pressure may continue even after laser iridotomy. Just keep in mind that making a laser iridotomy may not be the final solution. Chronic angle closure has less dramatic IOP elevations, but may also be associated with occasional pressure spikes. Primary angle closure glaucoma causes almost 1/2 of the blindness attributed to glaucoma worldwide. When treated at the appropriate time with laser iridotomy or cataract surgery, it can be fundamentally improved, if not totally cured. Much of the primary angle closure glaucoma blindness may be preventable if you are careful enough in your decisions. The anatomy of the angle closure eyes pose a therapeutic role for lens removal. Laser iridotomy widens the anterior chamber angle, but some iridotrabecular contact persists in most patients, and angle closure may progress despite a patent iridectomy. Cataract surgery has found to be a more effective treatment for an attack of acute primary angle closure than laser iridotomy. The phacotrabeculectomy has the capacity to improve IOP 1.25 times more than clear lens extraction. But still, clear lens extraction has a good way of also treating this kind of patients. Apparently, phacotrabeculectomy group has more complications than the cataract surgery alone group. The author preferred phacoemulsification because of decreased complication rate. Studies found that 14.8% of uncontrolled patients and 2.9% of controlled patients eventually required a trabeculectomy. Richard Nestorm devoted his lecture in 2008 at American Academy of Ophthalmology as he was giving Kelman lecture, discussing the evidence of recommending cataract surgery as a treatment for glaucoma. And we have long experience doing this surgery to prevent angle closure. More common in women than in men, and a study that constructed prevalence models of angle closure from population-based studies found that women make up to nearly 70% of all patients with angle closure glaucoma, which is a serious problem for women. There are multiple studies that cataract surgery can decrease intraocular pressure, but there are questions. Is the reduction of IOP after cataract surgery is proportional to the preoperative IOP? Is the reduction in IOP after cataract surgery is same both in open and closed angles? Are the ratio of the preoperative IOP to ACD and axial length correlated with the magnitude of IOP reduction? And it was looked, and the results were as follows. Nearly, as the pressure is higher, nearly 100% of the cases have a pressure decrease, where also the maximum amount of pressure decrease is achieved when the pressure is higher preoperatively. And the amount of pressure that is decreased is approximately 5.3, which is a very acceptable value. The correlation between change in the IOP and the axial length was 0.20, but this was a good change, but it was not statistically significant. A shallower anterior chamber associated with greater decrease in IOP after surgery. So these are the important clues that we have to consider in our decision making. Anterior chamber depth and IOP reduction may be a good predictor of IOP reduction after cataract surgery in eyes with glaucoma. And for these cases, an index based on a ratio between preoperative IOP and ACD that was prepared, and that was strongly correlated with the magnitude of the IOP reduction post-operative device. And this is also a good way of looking how you diagnose and make your final decisions. Well, how the mechanism is like? The studies suggest that IOP improves because the anterior chamber deepens and the angle widens after cataract is removed. Studies have documented that the anterior chamber depth increases and that the angle becomes more open. Eye pressure reduction after cataract surgery was strongly correlated with the preoperative IOP, modestly correlated with anterior chamber depth. So when you see a preoperative IOP that is higher preoperatively, then the likelihood of getting a better decrease in the intraocular pressure is very high. The decrease in IOP was not significantly correlated with axial length, and although there was a trend toward an increase in IO production in shorter eyes. Cataract surgery performed following trabeculectomy is technically challenging, carries more risks, hypotony, and may disturbing the blood are the problems that may be a strong problem as you face the patient. Cataract surgery prior to glaucoma also has whatever the IO production may occur and avoids the ongoing infection risk of filtering blood. It's better that if you perform cataract surgery before glaucoma surgery, also it is a simplified operation, and you can reform shallow or flat anterior chambers easily. But if you do the other way around, then you may encounter somehow malignant glaucoma problems. Role of clear lens extraction in angle closure glaucoma is also should be discussed in detail. There are no published studies of role of clear lens extraction in treating angle closure glaucoma. Thomas L. recommended laser peripheral iridotomy rather than clear lens extraction. In their assessment, the low risk of acute primary angle closure following laser peripheral iridotomy does not justify a clear lens extraction. They do recommend consideration of clear lens extraction when IOP is elevated despite medical therapy, and a significant portion of the angle has not been permanently closed by peripheral anterior synechia. All these papers were the highly cited papers, so the information here are mostly very reliable one that we have to consider in our decisions. The success of cataract surgery alone in primary angle closure may depend on the reversibility of the angle damage and the target IOP. What do we understand with the angle closure? Patients with primary angle closure by definition have narrow angles and some oppositional closure and at least 3 quadrants with IOP elevation, but no glaucoma damage. Goniosynostosis also can be combined with clear lens extraction, and this may help to reduce the IOP. There are no studies comparing the risks and benefits of phacoplast goniosynostosis with phacoemulsification alone. There are some critical issues for clear lens extraction, and how to define the extent of angle closure is somehow a troublesome point that we have to consider. How to predict the degree of reversibility? Clinicians rely on gonioscopy to assess angle closure, and this evaluation takes great skill to perform, and it is highly subjective. Ultrasound and optical coherence tomography can also image the angle, and the techniques and standards for these modalities are evolving, and still there's a lot way to go. The IOP level and the response in the to laser peripheral iridotomy or cataract surgery may not correlate with the appearance of the angle. The angle appearance may not correlate with the severity of the glaucoma. Previous iridotrabecular contact may impair outflow even though the angle appears open. Here, how we performed some clear lens extractions. These patients have been highly hyperopic, so the anterior chamber was very narrow, and we get into the eye and we remove some vitreous from the back of the eye, and this was somehow helpful in removing our cataracts safely. They often have small pupils from previous either pilocarpine use or iris epithelium adherence to the anterior lens surface from repeated laser iridoplasty in an unsuccessful attempt to pull the iris out of the angle. Additionally, after the challenges of the operation, there is a high risk of postoperative malignant glaucoma and other serious complications that we have seen. So, we have the technology. We have here, femtolasers solved most of the issues that we encounter when we are treating angle closure glaucoma. This 2-minute video will show us how we can benefit femto with for angle closure. We use Varion as a digital guidance, and Varion helps a lot to make the location of the location of the incisions and many other points. And of course, the capsulex is around 4.6 millimeters here, but it is perfectly all right to proceed in a case with this kind of problem. Once we apply femtolaser, we remove the anterior capsule, and then we get ready for the cataract to be removed by phacoemulsification. We elevate the iris so that we can put a pupil dilating agent, namely Malюgin ring here. And once you elevate it, you can easily apply Malюgin ring without disturbing the environmental structures. And then we use a hybrid pattern here. The central 3 millimeter core is removed. And the IOP we are using is very low here. And in this cases, the IOP, preset IOP is crucial. Higher IOPs may endanger the optic nerve. So it's better that you work with the low IOP levels. And once you divide it into pieces, the rest of the surgery is cheese and cake. And once nucleus is removed, the cortex is easily removed by a polymer tip, and intraocular lens is safely implanted into the capsular bag, and of course Malюgin ring is removed first, and then the viscoelastic is aspirated following this surgery. So, cataract and angle closure glaucoma. The question is, how would you proceed? With further testing, would you order to identify the underlying cause of the patient's anterior angle closure glaucoma? If the patient requires surgery, would you perform cataract extraction, a trabeculectomy, or a combined procedure? Would you perform goniosynostosis? What are the indications for this procedure in this setting? If you perform a lensectomy, what refractive endpoint would you target, and how you are going to achieve it? These are the questions when you encounter this kind of patient. And I believe once you consider using good diagnostic tools and increase your ability to understand the angle of the eye, you will be in a better position to understand it. Many thanks. Thank you.
Thank you, Baker. We know that in many eyes with angle closure glaucoma, we face a narrow pupil. However, narrow pupils are not only related with narrow angles, but also with other conditions. And now we will hear our host, Professor Malюgin, very well appreciated surgeon all over the world, speaking about the myotic pupil.
Добрый день, глубоко уважаемые коллеги. Я сегодня буду говорить о оперативном лечении катаракты у пациентов с узким зрачком. И поскольку мой доклад является частью ESCRS Academy, я заранее извиняюсь, что слайды мои на английском, но, естественно, комментировать я их буду на русском. Мы знаем, что причинами узкого зрачка могут быть возрастные. В нашей популяции нередко это псевдоэксфолиативный синдром, диабет, воспалительные заболевания и ряд других. На вопрос о том, имеет ли размер зрачка значение, нет совсем уж однозначного ответа, поскольку если вы посмотрите на вот этого пациента, то здесь диаметр зрачка вовсе не такой уж и маленький, как в этом случае. Однако мы видим, что радужка вставилась через основной разрез и через парацентез. и явно у этого пациента будут сложности и проблемы технического характера в ходе операции, которую хирургу придется преодолевать. И благодаря работе Дэвида Чанга и Джона Кэмпбелла мы узнали, что значит состояние под названием синдром флоппи айрис или синдром трепещущей радужки, можно так перевести, который является триадой симптомов. Это трепетание радужки под действием ирригационных токов, это постепенное сужение зрачка в ходе операции и вставление радужки через основной разрез и через парацентез. Вот такая ситуация, как правило, наблюдается у пациентов, которые принимают альфа-адренергические агонисты альфа-адренергических рецепторов, чаще всего при гиперплазии простаты или при аденоме простаты. И впервые этот эффект был отмечен при приеме препарата тамсулосин или фломакс, однако в последующем он был отмечен и при использовании других препаратов. И причиной этого было то, что толщина дилататора мышцы, расширяющей зрачок, у пациентов контроля по сравнению с пациентами, принимающими данную группу препаратов, была существенно тоньше. Вследствие этого радужка теряла мышечный тонус, и это приводило к вот этому характерному трепетанию радужки. Далее были изучены самые различные варианты данных препаратов, селективные и неселективные, и открыты также и другие механизмы воздействия. Мы знаем, что мышца-дилататор делит ядро, клеточное ядро, совместно со слоем пигментного эпителия. Вот эти ядра, и у экспериментальных животных, которых кормили тамсулосином, было выяснено, что вот эти ядра клеток деградируют, и, вероятно, это нарушает проводимость и функциональную сократительную способность мышцы дилататора радужки. И мы видим, что так же, как и на кадаверных глазах, толщина дилататора существенно меньше, чем в контроле. И очевидно, что такие осложнения, первоначально была описана частота осложнений, равная 12,5%, и такие осложнения, как частичная или полная утрата радужки или ее сегмента, приводят к существенным косметическим и функциональным дефектам, поскольку очевидно, что этих пациентов будут мучить засветы и в вечернее время, и, скорее всего, и в солнечную погоду. Технические проблемы, которые сопровождают хирурга у пациентов с узким зрачком, изложены здесь. Это снижение рефлекса с глазного дна, поэтому нам сложнее выполнить капсулорексис. Очевидно, что повреждение радужки, кровотечение, пролапс. Но также, если мы оперируем пациента с узким зрачком, то получается, что мы вынуждены делаем капсулотомию меньшего диаметра. При меньшем диаметре капсулотомии мы повреждаем его чоппером или ультразвуковым наконечником. А если не повреждаем, то, как правило, такой капсулорексис малого диаметра сопровождается склонностью к фимозу и сокращению, а мы знаем, что это в сочетании со слабостью ценовых связок приводит к дислокации блока ИОЛ-капсульное кольцо, ИОЛ-капсульный мешок и так далее. И целый ряд технических проблем, недостаточности и сложности при удалении кортикальных масс, позиционированием торических линз и помещением гаптики интраокулярной линзы точно в капсульный мешок. Вот здесь еще приведено одно исследование, где изучались селективные и неселективные адренергические препараты, адреноблокаторы. И вот самое интересное в этом исследовании, пожалуй, для меня было то, что мы в принципе можем предсказать синдром Флоппи-Арис, просто оценивая степень дилатации зрачка у пациентов перед операцией. Вы видите, что здесь, вот в этой группе, где дилатация была несущественна, ну, вернее, существенно меньше, чем в контроле, то в 3,8 раза у этих пациентов повышался риск возникновения в ходе операции синдрома Флоппи-Арис, и это отмечалось у 79% пациентов по сравнению с 20% в контроле. Еще одним интересным исследованием в этом исследовании лично для меня было то, что даже у пациентов, которые не принимали никаких препаратов, у которых не было никаких факторов риска, нормальные пациенты, 14% от этого количества пациентов у них был синдром Флоппи-Арис. То есть даже если мы не получаем из анамнеза каких-то факторов риска, 14% наших пациентов могут давать нам такое осложнение. Это связано с анатомическими особенностями самой радужки и предрасположенностью к этому синдрому. Мы знаем, что в хирургии есть целый ряд приемов, которых хирургу следует придерживаться. Использование адаптивных вискоэластиков считается предпочтительным при операции на узком зрачке. Снижение параметров, гидродинамических параметров, уменьшение уровня вакуума и частоты аспирации, снижение высоты ирригационной бутыли, манипуляции в самом центре передней камеры, когда хирург не заходит под радужку и ни чопером, ни ультразвуковой иглой. И вы видите, что в этом случае, несмотря на то, что зрачок достаточно маленький, и это, в общем-то, не создает больших трудностей для хирурга, в частности, еще и потому, что у этого пациента радужка достаточно ригидна, и нет тенденции ее к пролапсу, и, соответственно, используется, естественно, соответствующая корректная, адекватная техника операции и параметры. Но, тем не менее, те сложности с эвакуацией кортикальных масс, они, в общем-то, и в этом случае были актуальны, но, тем не менее, и сам хрусталик, и кортикальные массы были удалены и поставлена интраокулярная линза. Это пример такого последовательного алгоритма действий хирурга, которому следует придерживаться. Мы все любим вводить мезотон в переднюю камеру. К сожалению, мезотон в последнее время стал нам все менее и менее доступен. Но, тем не менее, пока мы еще можем. Эпинефрин вводят наши коллеги. Мы знаем, что кардиологи любят использовать его в своей практике. К сожалению, он менее эффективен, чем фенилэфрин. Поэтому ожидать расширения зрачка мы можем, но до определенного предела. О использовании вискоадаптивных препаратов я сказал, а все последующие манипуляции мы обсудим на видеопримерах. Вот введение мезотона в переднюю камеру 1% сопровождается выраженным медриазом. И, естественно, в таком случае мы используем нашу стандартную обычную технику факомискации. Мы вводим мезотон и этому пациенту, видим, что здесь псевдоэксфолиативный синдром, и этот препарат эффективен, но, к сожалению, эффективность его недостаточна, и, соответственно, в результате мы получаем зрачок большего диаметра, но явно недостаточный для того, чтобы продолжить операцию безопасно. Здесь задние синехии, мы видим, что это пациент с оперированной глаукомой, здесь зона антиглаукомной операции. И мы видим эту синехию, она достаточно нежная, ее рассечение не представляет проблем, и можно продолжать операцию. Далее здесь синехии более интенсивные, примерно 130-140 градусов по дуге окружности, но тоже их рассечение не представляет сложностей и не затрудняет, по большому счету, хирургических манипуляций. В отличие от этого случая, где у пациента с хроническим воспалением переднего отрезка глаза УВИД привел к тому, что сформировалась зрачковая мембрана Как правило, такая зрачковая мембрана очень плотно адгезирована к радужке, но практически не прикреплена к хрусталику. Вы видите, она как легко отделяется от хрусталика, и иногда вот эти спайки между радужкой и мембраной настолько выражены, что есть риск оторвать радужку от корня, если это достаточно такой серьезный случай и воспаление было существенным. Иногда бывает сложно даже найти отверстие в этой мембране, чтобы провести диссекцию этой мембраны и удалить ее из зрачковой зоны. Иногда приходится использовать бимануальную технику, когда используются два инструмента. Один фиксирует радужку. Ну, естественно, мы в ряде случаев ожидаем кровотечения. Как правило, оно не очень существенное и может быть купировано либо введением вискоэластика, либо тампонадой активной передней камеры физраствором и повышением давления, и оставлением на некоторое время. Здесь более такой серьезный случай, когда вследствие воспалительных изменений переднего отрезка часть сфинктера превратилась в такое фиброзное кольцо, которое невозможно разделить каким-либо другим способом, кроме рассечения. Поэтому мы используем инструмент 25-го калибра, ножницы, и эта технология называется множественная сфинктеротомия. Она описана во всех учебниках по офтальмохирургии с разных углов, с разных положений. Рассекается это фиброзное кольцо или синехии. Понятно, что это приводит, опять же, и может приводить к кровотечению, но в таком случае зрачок достаточно для того, чтобы выполнить операцию дальше. Расширение зрачка, мы знаем, может быть достигнуто и при помощи различных инструментов, в частности, это крючки. Но мы в своей практике больше любим использовать капсульные крючки, нежели чем зрачковые крючки, потому что в этих случаях, когда мы их применяем, можно заодно фиксировать еще и переднюю капсулу хрусталика и преодолеть частично хотя бы слабость ценовых связок, которые нередко встречаются у этой категории пациентов. И вы видите, что зрачок хоть и не большой, и в общем-то он треугольной формы, поскольку введены 3 ретрактора, но тем не менее это не представляет большой проблемы, и операция заканчивается по стандартной технологии. Когда мы говорим о ретракторах, о крючках, мы должны помнить, что слишком сильное растяжение зрачка при использовании этих устройств не очень рекомендовано. Здесь оптическая когерентная томография переднего отрезка глаза. Мы видим переднюю поверхность хрусталика, радужка, и мы видим на осети тот крючок, который был введен, и мы видим, как он приподнимает радужку. Соответственно, 2 момента здесь являются критичным. Это дизайн, 3 даже, да, дизайн этого устройства, это угол, под которым вы выполняете парацентез, и степень растяжения зрачка, и степень натяжения вот этого фиксирующей силиконовой шайбы, которая регулирует диаметр зрачка. Вот это очень интересное и элегантное, с моей точки зрения, решение было придумано доктором Аси из Израиля. И суть этого устройства в том, что, в общем-то, оно действует как зрачковые крючки или крючки для радужки, но для их установки требуется в 2 раза меньшее количество разрезов и в 2 раза меньшее количество парацентезов. И поэтому в определенной степени эта технология менее травматична, и поэтому мне кажется, что использование такой технологии вполне оправдано. Здесь эти устройства одноразовые, снабжены одноразовым специальным пинцетом, и вы берете это устройство из специального держателя и вставляете в парацентез. Но, честно говоря, я не очень люблю использовать зрачковые крючки или вот все девайсы или устройства, которые нам дают форму зрачка в ходе операции квадратную. Почему это так? Ну, в общем, мы вспоминаем геометрию, и все достаточно и примитивно просто. А простота здесь в том, что периметр квадрата, он больше, чем периметр круга. Соответственно, при практически равном диаметре, при использовании крючков мы, как правило, перерастягиваем ткани радужки, и они повреждаются существенно больше, чем при использовании колец и при использовании зрачковых колец. Понятно, что мы можем увеличить количество крючков, и действительно было показано группой наших коллег, почему 5 лучше, чем 4, потому что на 17% уменьшается длина периметра, но понятно, что увеличивается количество парацентезов, и это тоже не очень практично. Зрачковые кольца, их было много предложено, самых разных вариантов. В историческом аспекте кольца Морчера, Милвелла, видите, выполнены из ПММА или из силикона. Вот это более современные дизайны, которые появились относительно недавно, где-то в ближайшие примерно 3 года. Кольцо BVI, Diamatrix и iRing, которые сейчас начали более широко использоваться в клинической практике. Ну, я, естественно, люблю тот девайс, к которому приложил руку, создавая его. Но самое интересное в этом устройстве, с моей точки зрения, то, что, несмотря на квадратную форму устройства и 4 фиксационных элемента, которые держат зрачок, он на самом деле обеспечивает круглую форму зрачка. Это потому, что в месте перехода между двумя углами этого устройства имеется еще дополнительная точка фиксации зрачка. И таким образом мы как бы виртуально внедряем 8 зрачковых крючков и, соответственно, не перерастягиваем радужку и не даем ей варианты сходные с квадратной формой. Это устройство выполнено из полипропилена. И видите, что имплантация, она уже была показана, она достаточно проста, производится при помощи инжектора, хотя можно сделать это и вручную. Но инжектор, понятно, более удобен, так же, как и линзы мы любим инжектировать в глаз, так, собственно говоря, и все остальные устройства легче и проще имплантируются при помощи инжектора. Как правило, при этом используется еще один инструмент, так называемый манипулятор, который помогает нам установить это кольцо в правильное положение, или, как говорится, дальше проводить соответствующие манипуляции. Ну, вот один клинический случай. Как правило, 2 боковых кольца при инжектировании, они входят в контакт с радужкой и практически одновременно, но иногда для этого приходится приложить определенные усилия, ротируя и позиционируя кольцо соответствующим образом. Ну, собственно говоря, дальнейшие этапы этих манипуляций вы, в общем-то, сегодня уже видели. Дэвид Чанг показал, что данное устройство неплохо помогает у пациентов с синдромом флоппи айрис. Не буду останавливаться на деталях этой техники. Вот покажу лишь, как он развивается. Посмотрите, когда только из парацентеза вышел весь вискоэластик, который был в передней камере, мгновенно зрачок сузился, радужка начала вставляться через парацентез, и мы видим, что она трепещет под действием ирригационных токов, и зрачок потихонечку сужается. И вот здесь, конечно, сразу резко возрастает риск повреждения зрачка. Интересное предложение сделали два наших иранских товарища, которые предложили использовать два латеральных фиксационных элемента для того, чтобы зацепить капсулу хрусталика. И по их данным, такое расположение, такая фиксация позволяет работать у пациентов с узким зрачком и слабостью ценовых связок. Мы в этом году опубликовали еще одну интересную технологию вместе с моими коллегами Натальей Анисимовой и Николаем Соболевым. Использование данного устройства совместно с крючками у пациентов при лазерной экстракции, у пациентов с эктопированными зрачками. Мы знаем, что лазерная экстракция порой сопровождается сужением зрачка, и мы можем преодолеть эти проблемы при помощи различных устройств. Второе поколение устройств имеет более тонкую структуру, более тонкую нить, и поэтому оно более оптимально с точки зрения введения через малый разрез, который не превышает 2 мм, и, соответственно, более высокая эластичность дает возможность в меньшей степени травмировать радужку и получать более оптимальные результаты. Таким образом, использование у пациентов с узким зрачком использование так называемой последовательной технологии, этапной технологии принятия решения позволяет в ряде случаев отказаться от некоторых ненужных этапов, и введение каких-то механических устройств на самом начальном этапе операции с нашей точки зрения нецелесообразно. И очевидно, что все механические устройства, крючки, кольца – это самое последнее решение, которое вы должны принимать, когда все остальные манипуляции не приводят к желаемому результату. И я благодарю вас за внимание. Спасибо.
Thank you, Boris, for this excellent presentation about one of your topic of interest for your research. Now we move to Italy and to Dr. Morselli, who will speak about a micro-incision glaucoma surgery or mini-invasive glaucoma surgery, and she will explain techniques and so on. Simonetta.
Thank you very much to invite me in this very wonderful venue, and thank you, Boris, to invite me. To speak about mini-invasive glaucoma surgery. And this is my financial disclosure. And in 2016 appeared this paper where we can find the definition of mini-invasive glaucoma surgery. It's an ab-internal approach with no conjunctival dissection for IOP reduction. And what is the definition of filtering surgery? Is the IOP reduction through artificial drainage between anterior chamber and subconjunctival space. Well, how can we obtain the increase of aqueous humor deflux by micro-invasive glaucoma surgery? To trabecular Schlemm canal, with trabectome, with iStent, with hydrostent, with GUT, and with ALT. Or into suprachoroidal space with iStent, with CPAS microstent, or into subconjunctival space with Xengel stent. This is the last new device that I have a lot of experience. This is my experience with a trabectome. It was not so nice because the visibility is often difficult. The tip movement to follow should follow a cycle, but sometimes it's very difficult. 3-4 o'clock hour maximum of the treatment, and sometimes there are outer wall damage possibility. And also, to complicate at the end, the bleeding is very common. And when there is a bleed into the anterior chamber, you cannot see anything, and you cannot treat the patient more with the trabectome. my experience is not so good. Even if in 2006 appeared this paper that defined that trabeculectomy was an internal trabeculectomy. Anyway, what about the trabecular stent? There are a very small device that is implanted into the Schlemm canal. The technique is quite difficult because you must put the microscope tilt 30 degrees. The patient's head is rotating 45 degrees. Is like a chopper position, motorbike position. For me, it was very difficult because I am small and not too big. And the technique is to do only a little incision into the anterior chamber, then put the viscoelastic, then with the gonioscopic try to understand where is the channel, the trabecular meshwork, and the position of the eye stent is demonstrated by the red arrow. Then you go inside of the anterior chamber under gonioscopy, and the eye stent self-penetrating in position just above the scleral par. 1/3 the distance between the scleral par and the anterior edge of the pigmented meshwork is easier to say and to see, as much difficult to do. And then this is the technique. Okay, if you do everything okay, at the end, the day after surgery, with the gonioscopy, you can see the device into the Schlemm channel. This is a C-pass technique. The device is implanted through anterior chamber to the suprachoroidal space, but I don't have experience. It's only to demonstrate to you that this device is existing and into the market. But I think that today the only filtering micro-invasive glaucoma surgery, in my opinion, is Xengel stent. What are the advantages of subconjunctival filtration? Aqueous humor filtration is not only due to venous system drainage through Schlemm canal or uveoscleral space, but also through conjunctival and lymphatic diffusion. Bypassing Schlemm's canal, we can avoid more obstacles for aqueous humor drainage. And there are a lot of references that appear recently in literature that demonstrate that Xengel is an internal approach combined with phacoemulsification is a mini-invasive glaucoma surgery and give us a very good results after surgery, even a very long follow-up. What is this device? Is 6 mm length, 45 mm diameter, is a porcine collagen cross-linking with the gluteral day transformed in jelly. It's hydrophilic, it's flexible, and also is very biocompatible. It's preloaded, it's injected in one injector. It's 25 gauge needle, double beveled. It is designed to pass through the angle into the subconjunctival space, and the needle is retracted after implantation, leaving the stent in position. And what is the surgical step? Under topical anesthesia, 4% lidocaine, we perform temporal subconjunctival injection of 0.1 milliliter of mitomycin C plus 0.1 milliliter 4% lidocaine. And then there is a supranasal displacement of the injected fluid by a massage with a sponge. Then we perform phaco, then IOL implantation, pupil reconstruction, 3 mm mark from the limbus at the supranasal quadrant, 2 mm clear colon incision at inferior temporal quadrant. And this is the technique to insert and surgical procedure to insert. 25 gauge needle is passed through the angle until it is visible. Under the conjunctiva, you can see the mark, the blue mark. needle rotation towards 12 o'clock, and XEN injection, 3-hand technique. Because I have a very small hand, I am not able to inject the XEN with my hand. A third hand of my assistant I need, and also a manipulator is needed to block the eye because we are under topical anesthesia. The injector is retracted, the visco is removed, and then we perform hydrosuture with antibiotic, cefuroxime. And what are the indications? Some inclusion criteria: open angle glaucoma, pigmented glaucoma, Pseudoexfoliation, IOP between 18 and 35 mm of mercury, IOP less than 18 if the patient has drop allergies, and pseudophakia. What are the extreme exclusion criteria? Aphakia, neovascular glaucoma, and closer angle glaucomas. Relative exclusion criteria: previous glaucoma surgery. If you have a conjunctiva that is not blocked, that is not scarred, we can perform this surgery. Uveal glaucoma is a relative contraindication, and phakic eyes is relative contraindication. We perform 2 cases of this in 2 phakic eyes with open angle glaucoma. This is our series of patients, 33 eyes with longer follow-up that we have. And these are our results, and we obtained a very good results even after 1 year of follow-up. Only one patient, it was monocular patient, obvious, underwent filtration surgery, and also 4 patients come back to monotherapy to maintain the IOP at good level. This is the IOP reduction after 1 year. You can see that it's 31.10% of IOP reduction after 1 year, and remains stable. We have some complications, but very small complications. Subconjunctival hemorrhage during mitomycin injection that obliged us to stop the surgery and postpone the surgery. Anterior chamber bleeding from trabecular meshworks or iris, and uncorrected positioning. For the post-operative, subconjunctival hemorrhages and unfiltering bleb, and 2 uncorrected position and 1 obstruction of the XEN gel. In conclusion, in my opinion, is the first filtrating microinvasive glaucoma surgery. Not only my opinion, also in the literature there is a definition of this. It's even effective. Leaves virgin conjunctiva if future glaucoma surgery is needed. It is more safe in a post-operative, no choroidal detachment, no hypotony after surgery. And we find out other indication from our experience. Failed trabeculectomy, glaucoma patients with low IOP but with topical drug intolerance undergoing cataract surgery of pseudophakic patients, and also advanced glaucoma with good visual acuity. When we don't want to have complication after surgery. And thank you from my XEN staff. Thank you.
Thank you, Dr. Morselli. Now we have some time for discussion, and I will start discussion, and then we will look through comments from the audience. We have translations, so we can answer questions. I would like first to ask Professor Aslan from Turkey. He mentioned that clearance extraction. You mentioned clearance extraction is an option in angle closure glaucoma. Now, I would like to ask you, how early do you suggest surgery to those patients? If you see a 50-year-old lady with a very narrow angle and who is +3 hyperopic with clear lenses, do you suggest cataract surgery or laser peripheral iridectomy?
Well, I think in a 50-year-old lady, there are few remarks that I have to make. In a lady like that, the posterior vitreous detachment doesn't, if occurred, if you see a posterior vitreous detachment, you can directly, if the pressure is not controlled by other means, you directly can get into a stage of clear lens extraction. But if you see that the posterior vitreous detachment is not already occurred, then it may be nice that laser iridotomy may be the first choice. And then you follow the patient. So this is the way I go, and I rather recommend you that posterior vitreous detachment is one of the most crucial points for clear lens extraction. If you don't see that, then the likelihood of retinal detachment is very high in those cases. So take care for that important point.
Thank you. Any question to Dr. Aslan from the audience? Thank you. Now, I would like to pose a second question to Professor Malюgin. And my question for you is, now in Europe there is a registered drug to obtain mydriasis during cataract surgery, and it's Midran from TEA. I used it in a few cases of IFIS, and it works pretty well. So what's your experience about? Do you think this will help us even reducing the need for rings? What do you think?
Вопрос доктора Белуччи был относительно препарата, который недавно вышел в Европе на рынок, который производится компанией TEA, и название этого препарата Мидрейн. Мидрейн — это комбинированная, это смесь тропикамида, фенилэфрина и, по-моему, еще там есть немного нестероидного НПВС. И предназначен для внутрикамерного введения и расширения зрачка. Поэтому считаю, что это очень хорошо. Мы, правда, уже давно используем мезотон, уже сколько я себя помню, больше 30 лет, а может быть даже и больше. Поэтому для нас это как бы рутинная практика. Для европейцев это, ну, скажем, вот относительно недавно вошедшая в моду. Хотя некоторые из них использовали что-то и раньше, но в больших масштабах, так как это принято в России, этого не делалось. Поэтому для нас это однозначно рутина. Надеюсь, что мезотон будет нам еще доступен, потому что сейчас у нас есть перебои с поставками. Вот, так что очень жаль, что если мы этого лишимся, это будет, конечно, большая беда. Надо будет думать, что делать. И, естественно, чем больше мы используем внутрикамерных мидриатиков, тем меньше необходимость в кольцах, в крючках и прочее. Это здорово. Если мы можем без этого обойтись, лучше без этого обойтись. А еще в США еще зарегистрирован один препарат, который называется Омерос. Омерос вводится в бутыль с физиологическим раствором и как бы поступает постоянно и омывает радужку и переднюю камеру. Тоже там смесь, по-моему, НПВС и тропикамида. И по ряду исследований, которые к настоящему моменту опубликованы, позволяет поддержать диаметр зрачка в ходе операции. Это неплохо, правда, цена его достаточно высока. Даже для Америки это такая запредельная $500 за инъекцию. Но они пока получили специальное разрешение, которое позволяет им, ну, как бы, хирургическим центрам не платить за это, то есть платит государство. Потом через 2 года они пересматривают это и определяются, будет ли дальше государство платить, или как бы надо будет уже оплачивать как бы пациентам или там через другие какие-то системы. Поэтому сейчас вот как бы такое экспериментальное использование, а дальше как пойдет, мы пока не знаем. Sorry for the long answer, but it's it's like that.
Any question to Professor Malюgin from the audience? Everything is clear. Then I have a question for Dr. Morselli. We are accustomed to titrate the result of our glaucoma surgery. After trabeculectomy, we can change something to increase the result, to augment the result. Can something similar take place with mix and with Xangel stent? Once you see the pressure increase after surgery, can you do something to decrease the pressure?
Yeah, sometimes happen that the bleb, because it's a filtering surgery and there is a bleb and you must manage the bleb after surgery. Sometimes you have some cystis of the bleb and this could be the problem of a high IOP increase, and sometimes needling of the bleb is necessary to reduce the or sometimes the IOP, or sometimes you have the block of the bleb due to the scar of the bleb, and in this case it's necessary to repeat the surgery. We have a patient with 3 xen implanted in the same space because it's very small. It's very small because sometimes happen. Sorry, thank you. I have a question for you, Boris. Sometimes when I use your device, it's quite a little difficult to engage the two lateral. And I go inside the anterior chamber with the viscoelastic, try to elevate a little bit the iris and try to engage. Have you other tricks for us to engage better the two lateral?
How do you want me to answer, in English or in Russian?
I like to speak your language, but I prefer English.
Okay. Вопрос был о том, как какие-то технические моменты при имплантации кольца. Я, видимо, должен ответить на английском, потому что... So, it depends on what type of device. If you use first generation, it's a little bit easier to engage because the device is more rigid, and so it's less rigid in version 2, and that's why you usually need to add some viscoelastic under the iris. The other is sometimes when I see that I cannot engage both scrolls, so I try to go back and rotate a little bit the tilt to catch one and catch the other, and then do it like that. So sometimes it's help, but if it's not, so then just leave it, because sometimes, anterior surface of the lens is prolate, and you cannot press on it, and that's why it's a little bit higher. The center of the lens is higher than the pupil edge, so you will not be able to do that anyway. So you just leave it like that, and then use your manipulator and insert the device in place. Basically like that. Мы должны двигаться дальше. Следующий доклад профессора Белуччи. Это хирургия катаракты у пациентов, ранее перенесших кераторефракционную хирургию.
Спасибо, Boris, and thank you all for being here listening to this completely different topic as the previous one, that is cataract surgery after previous refractive corneal surgery, and this is my financial disclosure. So the refractive patient presented cataract surgery asking for regular simple things: good visual acuity and spectacle independency. And we deal with specific problems that may be IOL related, calculation of the power, IOL selection, and surgery related, the type of surgery, the incision placement, and so on. Definitely, to deal with those, we need a thorough ocular examination. We need to examine the retinal, macular, and optic nerve head condition. Then we go through our automated and clinical refraction to corneal tomography, to ocular biometry, and to power calculation. They will deal with all of those. First, the posterior segment. Every visual problem is a cataract for the refractive surgery patients. They even an increase in myopia or an increase in the macular degeneration is cataract, and it should be removed by us. So we need a thorough examination of the posterior segment to discover, mainly through OCT, if the macula is good, and then we can go with microperimetry or perimetry, especially in high myopia. We will discover how often there are problems at the macular level that cannot be solved by further surgery. Then we go and consider the differences between the automated and clinical refraction, because after corneal surgery for myopia, the clinical refraction is usually more hyperopic than the automated refraction, indicating a flatter central cornea than that considered by the machine, because by exaggerating, the cornea has the shape in this small picture. So we must go through our corneal tomography to investigate the corneal shape and asphericity, the relation between the anterior and the posterior corneal surfaces, the regular astigmatism, that's rarely the case, and the axis for any torical IOL placement, the irregular astigmatism that mainly is due to a previous procedure, decentration, and corneal aberrometry. Corneal aberrometry is especially important because if the high-order total aberration are below 1 micron, we can end up with good visual quality in the post-op. But if the high-order aberration are above 2 microns, usually the vision will be unsatisfactory after cataract surgery. And then we should consider spherical aberration that is positive after myopic LASIK PRK and negative after hyperopic LASIK and PRK. So these are two aberration profiles. On the left, an eye with a 12-incision radial keratotomy, and these are the 3 millimeter and 5 millimeter optical zone aberration map. On the right, LASIK for the same amount of myopia, 3 millimeter and 5 millimeter optical zone, and we see that the aberration after LASIK are, of course, lower than the aberration after RK, indicating a potential good outcome of our cataract surgery. And this is the optical quality in the same eyes, and we can tell the LASIK patient probably visual quality will be good in the post-op as compared with the post-radial keratotomy patient. However, both those patients that are actual patients were perfectly satisfied with the result, meaning that what the patient thinks is so important for the outcome. Then we go to our ocular biometry. The axial length is not influenced by our corneal refractive surgery, but K readings are not affordable, both because the corneal refractive index is no longer valid, because it considers the anterior and the posterior surface to be parallel, and there are no parallel after corneal refractive surgery, and because the measured paracentral cornea is steeper than the central cornea, as I said before. And then the effective lens position cannot be anticipated because the new Ks are not predictive of effective lens position, and hence the double K formula of Alan Berry, who suggested to use the pre-refractive surgery K reading to predict the effective lens position, and the new K reading to predict the IOL power. Regardless the surgery, the outcome with common formulas of the power calculation will be inaccurate. If after previous myopic surgery, the patient will end up hyperopic, and after previous hyperopic surgery, he will end up myopic, unless we use specific power calculation formula. And now there are several useful formulas that can be obtained in the ESCRS online calculator, but also in the Asia Pacific Cataract and Refractive Surgery Society online website, with a suggestion to use the Haig's formula targeting -1, -2, -3, after radial keratotomy, and the Hayes, L, the Sabini, or the Barrett-Turkey formula after laser vision correction. Especially, I see that the Barrett-Turkey is more and more employed in this regard. And the pre-operative data is no longer necessary for this type of calculation. I never use it. In addition, cataract surgery is an opportunity to improve high-order aberration because oblate corneas will benefit from IOLs with negative spherical aberration. Many IOLs now have negative spherical aberration. However, hyperprolate corneas will benefit from IOLs with positive spherical aberration. So old-shaped IOLs are still useful in this regard. And we might turn to aberration-free IOLs in most cases, but we will lose the opportunity to improve high-order aberration. And we know how important it is to correct spherical aberration, as you can see here in this Hartmann-Schack picture of true eyes. What about multifocal IOLs? Because those patients after refractive corneal surgery, they ask for spectacle independency. Now, can we use multifocals after LASIK? Probably not after PRK, but after LASIK. This is the literature I found. In 2008, first study by Alfonso, published in the Journal of Cataract and Refractive Surgery, he found that Acrylisa was slightly better than Restore after myopic LASIK. In 2009, he found that after hyperopic LASIK, 73% of patients were within half a diopter from zero after surgery, and so with multifocal intraocular lenses. And so his suggestion is, yes, we can use multifocal IOLs. Mutfloglu in 2010 found that 83% of eyes were within 0.5 diopter from emetropia after myopic laser. However, this percentage comprised 43% of laser enhancements. So calculations were not properly precise. And recently in Japan, a paper was published from the group of Hiroko Bissem-Najima, who is here, finding that if we compare the results obtained with multifocal intraocular lenses in LASIK eyes and the results we can obtain in non-LASIK eyes, we find the same result. However, lower contact sensitivity because LASIK is affecting contact sensitivity, as we know. So out of this literature, we find out that probably now it's safe and effective to use multifocal intraocular lenses in after refractive surgery patients. And actually, this is a medical doctor herself. I did surgery on last week, implanting in her second eye a trifocal intraocular lenses, and she is perfectly spectacle independent in the first eye. However, we must face some additional problem. For instance, dry eye that may come from LASIK surgery and also from cataract surgery. Then, can we affect astigmatism by incision location? I don't think so, because this type of astigmatism comes after laser refractive surgery, after excimer laser, and is an astigmatism different in the central part of the cornea than in the peripheral part of the cornea. And then, after LASIK, possible flap edema in the post-operative has been described. So this is a patient who underwent LASIK plus RK, and this is the Placido image, and this patient was perfectly satisfied after surgery. But what to do after presby-LASIK? This is an image I took 2 days ago in my office. This is a patient with presby-LASIK. when this patient will face cataract surgery, can I put a multifocal lens here? I don't think so. Can I put a monofocal lens? We can, but then how to deal with the residual refractive error? This is a question still open, and we will find solutions in the future, I hope. And then after radial keratotomy, we face the hugest challenge, because the cornea is often multifocal, and then in addition, we can observe a fluctuation of corneal astigmatism with IOP. However, my experience so far with after radial keratotomy is quite good. For instance, in this eye, I found a clinical refraction +4, an automated refraction +2, and this was the placebo image. I put a +30 instead of a +26, as was indicated by the online calculator, and the result was good distance and near vision with no correction at all. This was the contralateral eye of the same patient with a huge coma that apparently was not perceived by the patient. I did the same calculation, same result. Why? Because we face less problems of power calculation after RK, because the corneal thickness is maintained, the relation between anterior and posterior surfaces are not maintained, however. The ESCRS online calculation is useful, might be some hyperopic shift. However, as a rule of thumb, increase by 2 diopter the IOL power. But this may not be enough if we rely on the clinical refraction in the pre-op and compare the clinical refraction with the automated refraction with the K readings we use for IOL power calculation, and then we increase the power of the intraocular lens 1.5 diopter per diopter of refraction, we will find out a good result. And then we face the problem how to deal with this type of surgery. I don't use femto in those eyes because the bridges in the capsulotomy may easily develop. But the incision width is important here. We must go with mix. A 2.2 millimeter incision may be much too large, and so we might deal with the less than 2 millimeter incision in some instances. It's not difficult to do direxis. However, we must keep the bottle very, very low. I keep the bottle 40 centimeters above the head of the patient in those eyes, reducing the pressure in the anterior chamber, trying not to open the incisions, because most of those incisions were actually penetrating, and opening of the incision may develop at cataract surgery, and this luckily was not the case in this particular case. So we need a good machine allowing us to work with a very low pressure within the anterior chamber. And then a mixed lens is mandatory. An incised lens here was implanted through an injector that can implant this lens through a 1.5 millimeter incision. The result was good and corrected distance and near vision, a spectacle independency obtained. But this is not always the case. And we find refractive surprises commonly in eyes after corneal refractive surgery and how to deal with them. In the early postoperative period, we can think that corneal edema is changing the refraction, but late, how to deal with them? If the error is large, we can exchange the IOL, or we can provide the piggyback sulcus implantation. Now there are several companies producing piggyback lenses for sulcus implantation, and these can be used in those cases. But when we have enough of cornea to do a laser touch-up, we can go with PRK or LASIK to fix the result in our patients. In conclusion, cataract surgery is more demanding after refractive corneal surgery. not from a surgical point of view after excimer laser, but for power calculation and for the fact that those patients always ask for spectacle independency in the pseudophakia. But power calculation is overtaken by surgical difficulties after incisional corneal surgery that deal with small incision and low pressure within the anterior chamber. And multifocal IOLs, they are an option, however, only with low corneal aberration. Thank you for your attention.
Спасибо большое. Следующий доклад доктора Морселли будет посвящен вопросам хирургии катаракты на глазах с фокичными интраокулярными линзами.
Thank you, Professor Malюгин, at the time to invite me. Cataract surgery with the phakic IOLs. Okay, my financial disclosure. It's very well known that high myopia is associated with cataract. And especially when a patient is implanted with the phakic IOL, this increases the risk. Even with anterior chamber IOLs, iris fixating, and posterior chamber IOLs. In 2008, it was published a meta-analysis of cataract development after phakic intraocular lens surgery, angle-supported review. 1,161 eyes implanted with PMMA lenses. The mean follow-up was 27 months, and they found 50 new cataracts in a patient implanted with this type of IOLs. What's happened with the angle-supported foldable phakic IOL? Professor Conan, Professor Young, Professor Gimbel didn't find any cataract in 174 eyes implanted with Alcon Cachet. Also with corneal ECARE, I didn't find any cataract, but a lot of endothelial cell loss. That means that all these lenses were explanted from the eye of the patients, but no cataract was detected. What's happened with Artisan and Verisize IOL? In 2014, 213 IOLs implanted, 4 eyes developed cataract, and 1 eye developed corneal decompensations. What is the cataract prevalence? Catton in Ophthalmology 2008 published the incidence of cataract in patients in the group of 55 to 64 years old. He found that the cataract was found in 9.1% of patients. In this article of 2014, the eyes implanted with Artisan, cataract was present in 6.8%. That means that cataract normally is present in this group of patients, even if they are not implanted with phakic IOL. This is an Artisan review of 2008, a very large number of eyes, 41 with pre-existing cataracts, and 20 new cataracts were developed after 33 months of follow-up. What about ICL? 41 eyes, 8 years, 10 lens opacity, 25% were present before implantations and after implantation, and visual loss was very low, and the patients that required surgery due to the cataract were only 2 patients. Cataract still exists in these patients, but it not means that should be operated. This is another review that you can see a very large number of eyes, and 99.3% of patients presented new cataracts implanted with ICL. This is another review of 2011. You can see that when the time passes, the incidence of cataract is higher, and you can see that after 3 years is 6.3%. What are the most dangerous phakic IOL adapted for cataract and corneal care for the cornea, for corneal decompensation? And what are the indications for surgery to explant the phakic IOL and operate patient for cataract surgery? Vision, visual disturbances due to the cataract, refractive myopia, myopia progression and loss of accommodation, and anatomical, obviously, endothelial cell loss, pupillar ovalization, or glaucoma or other problems that myopic patients suffer. There are some issues when we perform biometry before IOL implantation. If refractive target is monofocal IOL, we can discuss with the patient for emetropia or low myopia. I suggest use Ballet Universal 2 formula because it's a little bit precise than SRKT. And also we must adjust the axial length and IOL material with silicone optical axial length plus 0.1, with Collamer optical axial length less than 0.1 millimeter. And also we take care about the retinal evaluation before surgery, because normally very high myopic eye had some problems in the retina. And what about the implant multifocal IOLs? I don't like personally implant multifocal IOL these patients after the ICL explantation. But anyway, there are three papers published in literature. Professor Koshner in 2014 had a good results, but what is the main concern is healthy retina. In all these cases, they had the good results because they had very healthy retina. That is very quite important for this type of patients. And what about surgery? What is the technique to explant surgery? These patients had high astigmatism on the roll. Astigmatism, and with this type of IOL, it's necessary to cut one loop. Then pay attention to the synechia into the angle, because when you perform this maneuver, sometimes the eye starts bleeding due to the synechia removal during surgery, and it's quite easy to explant the IOL, and also easy to explant the other loop. Pay attention if the loop is complete, there's no remnants into the interior chamber, then you can perform phaco. If you use microincision, phacoemulsification, sometimes it's necessary to stitch the incision because it's too large to perform cataract surgery and the anterior chamber is not stable. And what about the artisan? First maneuver is to disenclavate the artisan from the iris. Sometimes it's difficult, sometimes it's very easy. It depends on the synechia that we can find. Normally, I perform scleral incision in the steepest meridian and open the incision like the diameter of the IOL, a very delicate explantation, and sometimes, like I said before, it's necessary a stitch to close the wound and to have a better anterior chamber stability during surgery, and then the IOL implantation is quite easy. Okay. This is surgery ESCRS explantation. Also, you can see that the incision is placed on the steepest meridian of the cornea. And then the ESCRS is very easy explanted with 2 forceps. It's necessary to use 2 forceps because if you don't grasp it with 2 forceps, the risk is to break the bridge and it's quite difficult to explant the IOL. And now we perform phaco, and it's quite easy to implant the IOL. And this was one of the first PRL implanted. It was one of my patients many years ago that could maybe here to implant this new PRL. And this PRL was not correct in the length and was displaced into the eye and caused cataract. That was very easy to explant because it's a very flexible IOL. It's not necessary to open the wound too much to explant the IOL. And the monofocal IOL is implanted into the capsular bag without any type of problem. This was an hyperopic patient implanted with ICL. The patient suffers from Urles-Tavalia syndrome, like you understand here. And the PRL was very flexible and it was very easy to explant. Here, at another time, you can see that's very easy, and the incision is very small. It's about 2.2 millimeter incision. It is very, very, very soft lens. And now we are able to perform cataracts. Maybe there is a floppy iris. Maybe a Malюgin ring should be used in this case to maintain the iris fixed and not have a problem of the prolapse of the iris during surgery. It was a hyperopic patient, like you said before. The implantation was a high-power implantation. What about the complication? There are some intra and post-operative complications of cataract surgery, but are rare. Vitreous stents, especially in high myopic patients, can protrude through the zonula, and corneal decompensation can be accelerated. Myopia can progress further in the pseudophakia, and retinal issue continue to be important for this surgery. In conclusion, with phakic IOLs, an increase of cataract development up to 10% is expected only with PC, posterior chamber implants. And angle-supported implants may require explantation for corneal decompensation, as I said before, and posterior IOL removal and cataract surgery is readily complicated, and IOL selection and power must be discussed along with the patients. And thank you for your attention.
И последний доклад в этой части будет профессора Белуччи. Он посвящен вопросам замены интраокулярных линз.
Thank you. This is a question often patients pose to us, but can intraocular lenses be exchanged, or are they for our life? Both. They are for our life, but they can be explanted and exchanged for a variety of reasons. These are the reasons taken by a paper published by Davis in the US and compared with my experience. So in the US, they explant lenses mainly for dislocation, mainly for multifocal dissatisfaction, refractive reasons, uveitis, glaucoma, hyphema, and opacification. In Italy, we explant lenses because of dislocation. About dislocated lenses, Thomas Koenig will speak later on. We explant sometimes because they are multifocal, for refractive reasons, uveitis, I think I explanted only one or two for that. And I explanted most of them because of opacification and for other reasons. Of course, in the US, they don't implant hydrophilic intraocular lenses, so they see lens opacification less than we do. But let's start with early exchange. When the need for IOL exchange takes place soon after surgery, usually this is because there are refractive reasons or dissatisfaction from multifocal intraocular lenses. And despite the fact that recent technology has improved multifocal IOLs, still we deal with some dissatisfaction, and IOL removal is required. What is the actual explantation rate of IOL removal, and what are the results? Field studies in the literature are rare. In 2010, Mark Packer published a paper and said that 2.46% of Technis multifocal IOLs were removed. 2 were explanted to monofocal, and 4 of them were exchanged with multifocal for power calculation problems. In 2013, Dr. Venter published about a huge number, almost 10,000 of M+ lenses, finding out that only 80 of them were explanted. 26 were explanted to monofocal, 29 were exchanged to multifocal, and 25 were exchanged for malposition. So it seems that a very, very low number of implanted multifocal lenses are explanted. So is this a tale? Other field studies in 2010, Akaishi found no explantation out of 2,500 implanted lenses, and Kermani 2015 found only 12 restore removed out of almost 1,500, and only 8 of them were explanted to monofocal. A beautiful paper came from Japan, analysis of 50 explanted multifocal IOLs, and they found 1.2% explantation rate, and however 38 of them were explanted for optical disturbances, 0.89% of implanted multifocal. So we may think that actual explantation rate of multifocals is about 1%, so a very, very low number, and this is because of the unwanted optical phenomena they provide that are not tolerated by patients. Unfortunately, we know that these optical phenomena, disturbances, they decrease with time, and probably they decrease in a few cases after the lens was already explanted, but this is obvious. This is my personal experience, and it's very, very strange what happened to my patients, because around 1% of my patients asked for IOL explantation to monofocal because of a variety of reasons you see here. However, surgery is rarely difficult when we explain a multifocal IOL because the lens is not fixed inside the capsular bag, and the capsular bag has not undergone a contraction, and so usually YAG laser was not performed, so usually we can explain the multifocal and easily change it with another lens implanted in the capsular bag. A few lenses can be removed through a small incision, but with the old silicone model, we had to go through a lens cut just not to impair the astigmatism in this particular cornea. So the lens came out just in pieces, and a new lens can be implanted, and this was the same lens in the monofocal version. So we have a patient with 2 lenses. One was multifocal and the other was monofocal in the same eye, and these are the 2 aberrometric figures of those eyes, And we see that the aberration profile of the monofocal silicon techniques was better than the aberration profile of the multifocal silicon techniques, although both profiles were excellent. And the Strel ratio went from 0.27 to 0.41 after IOL exchange, indicating an increase in optical quality after IOL exchange. And this was documented objectively. However, 3 of my patients asked for the contrary, for monofocal IOL exchange to multifocal, because they wanted or had a multifocal in the contralateral eye, and one patient had an ammo array that was not a good lens from an optical point of view, but that lady was perfectly satisfied with it and asked for an exchange because a monofocal IOL was implanted by mistake in the second eye. And then also one patient had an icon restor in the other eye and asked for an icon restor in his eye with the monofocal IOL, the same for Hanita C lens, with a high patient satisfaction despite the anticipated LASIK, because those eyes with monofocal intraocular lenses usually have some astigmatism that needs to be fixed in the post-op. And 4 patients asked to exchange the multifocal for another multifocal. And this was my experience. One patient with a Restore plus 3 asked for a Restore plus 4 and was dissatisfied with the result. One patient with a Physio trifocal asked for a Nike Lisa bifocal and was dissatisfied with the result. While when we deal with dislocated multifocal lenses, patients are always satisfied with the result despite there were only 2. So the message is that the change of a multifocal IOL for another multifocal IOL when the lens is centered, when this problem, the need comes from patient dissatisfaction, didn't provide the expected result. How can we minimize multifocal IOL explants? Increasing patient selection criteria, more strict patient selection criteria, increasing chair time, thinking that complex optics require more precision in our power calculation. High myopes are often difficult patients, and I stopped implanting multifocals in high myopes. We should pay attention to macular condition. We should anticipate laser vision correction, and I learned not to mix IOLs. I always implant the same IOL in both eyes. Mixing them, matching means patient dissatisfaction in my experience. In conclusion of this part, multifocal IOL explantation accounts for about 1% of implanted multifocal lenses. Optical phenomena the main reason, and there is for sure less tolerance to anatomic inaccuracies with these lenses. Results of explantation are usually good, but multifocal IOL exchange, in my experience, was useful only for refractive inaccuracy and for IOL dislocation, not for solving unwanted optical phenomena. But the second reason for me to change IOL is a more difficult one, and is IOL opacification. Opacification can come out of the wrong material, especially hydrophilic acrylic, from manufacturing process, for method of IOL storage, surgical technique, and adjuvant. Because penetration of ophthalmic ointment, this was described in 2006, and patient-associated conditions like asteroid hyalosis, this is a common reason for IOL opacification, high myopia, uveitis, or subsequent surgery. It seems that if we put some air inside a pseudophakic eye, this is it's more easy than the IOL will opacify. any IOL can opacify. We should keep this in mind that IOL opacification has been described with PMMA, with silicone, with a hydrophilic acrylic, with a hydrophobic acrylic lenses, although hydrophilic acrylic showed the hugest opacification figures. When a lens is opaque, indications to IOL exchange are the same as the indication for cataract surgery, but surgery planning varies greatly across cases. Usually, I perform general anesthesia whenever possible because we cannot anticipate the duration of surgery. Then we should consider the corneal transparency, the level of mydriasis, and the YAG laser performed, because when vision decreases, immediately the surgeon performs YAG laser posterior capsulotomy that will make IOL exchange much more difficult. And then the IOL specific factors. So careful evaluation in mydriasis is mandatory. If the IOL has big haptic with large hole in the haptic, this will be a difficult lens to remove because of capsule sealing. Then we must consider IOL centration, capsular bag condition, and of course the occurrence of laser capsulotomy. The bag is modulated by IOL material. Hydrophilic acrylic promote contraction of capsular bag but are relatively easy to release. Hydrophobic acrylic promotes limited bag contraction but it's more sticky. PMMA promotes a little bag contraction with huge sommering strings because those are very old lenses and are relatively easy to release. Silicone lenses produce a huge bag contraction. They are easy to release but difficult to handle. So the first thing is to plan haptics release because, for instance, PVDF haptics are very sticky and must be thoroughly released, otherwise IOL rotation will break the zonula. Single-piece hydrophobic lenses are sticky, especially if there is a button at the edge of the loop. Single-piece hydrophilic lenses are less sticky and they are the easiest to release. Plate haptic, easy to lift without rotation. There is no need to rotate those lenses. And fenestrated haptics, the worst, as I say, the worst. And then in those eyes, we should expect low endothelial cell count, floppy iris, poor mydriasis, rapidly fading, unpredictable duration of surgery, and topical anesthesia is rarely suitable for those for that eyes, and the unpredictable outcome because refraction will change, and there is a risk for cystoid macular edema. But especially refraction will change, and if the patient had experienced full uncorrected vision when the lens was transparent, we should remind him that probably he will need spectacles in the post-operative after lens exchange, because the A constant is different, the lens position is different, and we cannot anticipate the refractive result. And what about the new IOL? 3 IOLs should be always available. A bag IOL of a different company and material, a sulcus 3-piece IOL, and an iris or scleral fixated IOL. We use iris fixated IOL mostly. What about the surgical steps? We need an adequate incision. Then we need to open the capsular bag to release or cut the lens haptics, the loop, to unscrew the IOL into the anterior chamber, and then we are ready to remove the IOL. Vitrectomy should always be available, and after that we should evaluate the capsule to decide where to implant the new IOL. There should be videos here, yes. I use a 30-gauge needle attached to viscoelastic to open the capsular bag and trying never to pull IOLs with C haptics. I try to release the haptics thoroughly before rotating the IOL, while IOLs with plate haptics don't need rotation. And the opening of the bag should be controlled before implanting the substitute IOL. This is an IOL of oculentis. Unfortunately, we had a cluster of IOL opacification recently, and this is the way we try to release the IOL. The haptics are not fenestrated, so this is not exactly a difficult task. We can unscrew this IOL. This was successful. And now that the lens is within the anterior chamber, we can remove it. In this particular case, the lens was cut. I found the trisector available not useful because it needs a very, very deep anterior chamber. That's not always the case. Remember to put an instrument beneath the IOL to act as a glide while we are removing pieces. And then after removal of the second piece is always easy to remove, we can implant the new IOL. More recent techniques, we will see them later, allow us not to cut entirely the IOL, but just to place a cut and the IOL can be rotated outside the eye. In this case, we put an hydrophobic acrylic IOL inside the capsular bag through the same incision, and the result was pretty good. So in this particular case, we had very, very little problem, no suture, and the outcome was good. Sulcus implantation. Sometimes we need sulcus implantation. In this case, we perform a frown incision not to increase the astigmatism, and then we try to release the IOL. This was expected to be a more difficult work because of the time elapsed since the IOL implant. However, the lens is hydrophilic acrylic, so it was rather easy to remove, and the new lens was implanted in the sulcus in this particular case because we felt safer implanting it in the sulcus than implanting it in the bag. And suture ends the surgery. Then we can deal with more difficult cases. In this case, the lens was partially cut and rotated outside the eye, but the posterior YAG laser was already performed, so now we have to deal with the vitreous. And for this reason, we made an anterior vitrectomy, and we decided we couldn't rely on the sulcus for the implant. So an artisan IOL was reverted and implanted, attaching it posteriorly to the iris. If we do this type of surgery, we should use an A constant for power calculation of 116.9 with this particular lens according to the literature. And we cannot forget the iridectomy that's required with this type of IOL. In the post-operative, we must expect increased inflammation than after regular cataract surgery and cystoid macular edema. We try to prevent cystoid macular edema through NSAID agents. In 1 year, the ESCRS study about CME prevention ruled by Rudy Nuit will be presented in Lisbon, and we will have the exact figure what is the best method to prevent cystoid macular edema. Then we must deal with astigmatism and suture control. The patient is always dissatisfied and he will be very, very negative in evaluating the result of surgery. And despite the fact that we employ generously NSAID and steroids, the post-operative period will be a little more cumbersome than the after regular cataract surgery. What does the literature say about opacified IOLs? They account 7% to 42% of explanted intraocular lenses. IOL opacification is more frequent with hydrophilic acrylic material. It appears both in clusters and as case reports, and time from original surgery varies between 6 and 200 months, with a mean of 36 months for hydrophilic acrylic, that is 3 years later than implantation. And diabetes is the only general risk factor determined. Are the results of surgery. What are the results of surgery? How do we end up with those eyes? Non-bag implant may account up to 70% of the exchanged IOL. And here are the results. Most of the eyes improve after surgery, not all of them. And in the paper published in 2007 by Siam, 186 eyes, only 53% of them improved. So IOL exchange for IOL opacification is not a simple thing to deal with. Post-operative complications are those of complicated cataract surgery, endothelial decompensation, hyphema, cystoid macular edema, retinal detachment, retained IOL fragment, and other case reports. In conclusion, IOL removal for late opacification remains a challenging procedure. Results are good with careful planning. Early removal dramatically reduces complications in published reports. And should easiness of removal be included in our alloy selection? This is a good question, and my answer is yes. I include the easiness of removal in my alloy selection. Thank you for your attention.
Спасибо большое. Есть ли вопросы профессору Белуччи? Я, пожалуй, задам один вопрос. Роберто, I will be interested in your opinion with regard to the first talk on keratorefractive surgery. What device would you prefer to use for these patients? Topographer, tomographer, or IOL master, or Lenstar? So what is your preferred method of taking K readings?
I use the Scheimpflug camera for K readings and the IOL master. And then I make a difference between the SIM-K and I compare the SIM-K with the automated refractor that usually has the same diameter. And then I consider the difference with the clinical refraction. And I change the K readings according to the difference of the clinical refraction. This because, especially after RK, patients use a 1.5 millimeter optical zone that's actually flatter than the K readings we see at 3 millimeter optical zone. So I suggest a Scheimpflug machine and a comparison between the clinical and the automated refraction.